Good morning and welcome to the 2019 AFTD Education Conference. I'm Ben Freeman from AFTD's staff, and I'll be your guide for this day of learning, sharing, and connecting with others in this growing community. Without further ado, I'd like to introduce the chair of AFTD's board, Gail Andersen.
Thank you, Ben. Good morning. Welcome to AFTD's 2019 Education Conference. I'm grateful to be here with all of you today. We are so pleased that more than 600 of you have chosen to find help and share hope with us today. There are 200 who registered for live stream and 400 in this room, which includes with us today people from more than 50 people living with a diagnosis of FTD, as well as caregivers and care partners, both current and former, healthcare professionals, and other experts in FTD. People have come from 40 different states and 3 Canadian provinces to be with us here today. I'd also like to acknowledge my fellow members of the AFTD board, as well as AFTD's CEO, Susan Dickinson, and the rest of the AFTD staff. Nearly the entire staff has made the trip from Philadelphia to attend the education conference today. Thank you for all you do for this mission and for bringing together this wonderful event. I am here with you today because this cause is personal to me and my family. We found help from AFTD at a critical moment in our lives. 2 decades ago, my husband was diagnosed with young-onset Alzheimer's at the age of 43 and then depression. But the diagnosis didn't quite fit. It took 7 years of frustration, but we finally learned the truth. He was living with behavioral variant Ftd. At the time, we had 5 young children in school. We barely knew anything about this strange disease, and it seemed like there was nowhere to turn. Fortunately, we found AFTD. For our family, AFTD was a beacon, providing crucial resources, expertise, and understanding at a time when accurate information about FTD was in short supply. The support group for parents with young children was a lifeline and connected me with people who understood the hardships and stress of raising a young family while caring for a BV-FTD spouse. As my family's FTD journey progressed, AFTD also became a way for me to make a difference. I committed myself to this organization, first as a member of the AFTD Kids and Teens Task Force, then doing Food for Thought events, and now as board chair. I am here to help other families who face this disease, and I'm here because my family continues to be impacted by ALS and FTD. And the idea of a future free of FTD has a vital importance for my family and all of us. By the end of today's conference, I hope you will have learned from the many leading FTD experts on hand and from each other as well. Making connections with others who understand FTD is maybe the most important way you can find help today. You are sharing a room with hundreds of people who can be a resource to you and your family. Whether they are researchers, medical professionals, care partners, or the strong advocates among us who live with this disease themselves. Connections like these have supported me through my FTD journey, and I encourage you to take the opportunity to make connections and share your experiences with one another. If you haven't gotten involved with AFTD as a volunteer, today is a great opportunity to learn about the many ways you can do that. Stop by our information tables to talk to AFTD staff, board, or a regional coordinator. Your conference booklet is a rich source of the range of supports that AFTD provides. You can read about AFTD support groups, volunteer opportunities, and informational resources starting on page 67 of our program book. Speaking of volunteering, AFTD's regional coordinator volunteers are here today. These valued contributors to AFTD's mission help to facilitate all the volunteer activity in their respective region of the country. Could the regional coordinator volunteers in attendance today please stand? You're out there. Where are you? Thank you. We could not do all that we do without your help and all the work you accomplish. Thank you. To those in the room who have been diagnosed with FTD, thank you for joining us. Your contributions to our understanding of FTD are invaluable. You add insight and urgency to our shared mission. Persons diagnosed will be presenting sessions throughout the day, and this year, Amy Shives, whom you will be hearing from shortly, was a core member of the conference planning committee. I'd also like to take a minute to acknowledge the generous sponsors of the 2019 AFTD Education Conference. Our platinum sponsors are Elector, Ionis Pharmaceuticals, and Buffalo Trace Distillery, gentlemen of the Pappy Van Winkle Classic. Our gold sponsors are Arden Courts Memory Care Community and Biogen, and our bronze sponsors are Alzheimer's Los Angeles and the Institute for Memory Impairments and Neurological Disorders at the University of California, Irvine. Thank you all for making this conference possible. The morning program will include with a keynote address from Martha Madison, an actor best known for her role on Days of Our Lives. This year, she is nominated for a Daytime Emmy Award, which will be held on Sunday. Martha's mother, Barbara, has been living with FTD for 15 years. We are grateful for her awareness efforts and that she is here to share her story with us today. Now it is my pleasure to introduce you to Amy Shives, a member of AFTD's think tank for persons diagnosed and a dementia advocate. Amy is here to officially kick off the 2019 Education Conference. Amy, welcome.
Hello, you can hear me. Please excuse me, I need to read this, unfortunately, but I do. It's just the best thing. I do have FTD. I realized while skimming this morning, I'm not sure that this says I do, but there you go. Begin. I am Amy Shives. I'm welcoming you all today, from the vantage point of a person who has FTD. Do not be alarmed should I fall off my shoes as I speak to you today. If I fall, it has nothing to do with the fact that I have FTD. I seldom wear cute, dangerous shoes. My daughter is seated here up front, and she is at the ready to leap up here and stand me up. And I'm really disappointed that you really can't see the shoes, so. They're coming off soon. I am pleased and proud to state that I am a member of the committee with the staff at AFTD that designed this conference, where we are all joined together today, either in person or remotely. As a full member of this committee, a committee in and of itself, I have had consistent input in the development of our agenda today for details and such. Through technology, I participated at every meeting personally. Our meetings were held in the offices of AFTD in Pennsylvania. I live in Spokane, Washington, across the country from Radnor, Pennsylvania. Very fortunately, technology has enabled me to sit at the table in Pennsylvania with my face clearly on the table via computer. Also, my voice, that tends to interrupt the proceedings fairly regularly. I don't know where the committee is, but that's the truth. I have behavioral FTD. The staff has been very kind to me. They have welcomed me into their staff community at AFTD as a member of their community tasked with bringing you this conference. AFTD is a leader internationally, having added to their mission a person with FTD as a stakeholder in the decisions made for the organization that invited you here today. It is common for other agencies that serve populations with disabilities to ask the persons they serve for input after the fact where decisions have already been made for the institution they work for. A rubber stamp, if you will. As a national speaker with other agencies, I have worked directly with this concept extensively. My experience with AFTD has been a very welcome change. What is exceptional here is the fact that I, a person with FTD, was invited to participate as a representative for people who have FTD at the decision table within the community. It certainly does not matter at all that it was me. What is important is someone with the disease was included at every step in the development of what you will see today. AFTD also has a group of people with FTD that form a community called ThinkTank. We advise the AFTD board on issues pertinent to the organization. Communities for support of our mission are at every level of the organization. What I truly wish for everyone today is that we discover there is a community available to everyone affected by the disease. We, who are present today, have networking opportunities in addition to the education we will experience later. I also hope that the people experiencing our day remotely will gain ideas and information shared here to find your own communities locally and online for support as we all battle through this FTD challenge. On behalf of the conference committee, and that brings you here to our conference today, and the board, I thank you for your attendance from near and far. Thank you all. We are truly a community to help one another in this journey. Thank you.
Thank you, Amy, for your valuable contributions to AFTD's work and for being here with us today. This morning's program features presentations from experts in FTD research and care. Please make note of questions during the talks and raise them during the breakout sessions this afternoon. We have built time for Q&A into the sessions after lunch, including 3 open forums with experts starting at 4. Research brings us hope for the future. AFTD's scientific director, Dr. Nadine Tatton, will introduce the presenters for our first session.
Good morning, everyone, and welcome, and it's so great to see you here today. I want to get this session started because we're tight on time. So we're going to begin with presentations on advances in our understanding of FTD, and it's my pleasure to bring up Dr. Mario Mendez and Jamie Fong up to the podium. Dr. Mendez will be our first speaker. He is the chair of AFTD's Medical Advisory Council, which is an invaluable resource for us. He is also a clinical neurologist at UCLA, and his efforts look at the clinical aspects of FTD, primary progressive aphasia, and other conditions. And he's going to give you an overview of FTD today. Dr. Mendez.
Thank you so much for the invitation. This is a wonderful organization. I remember I've done this before. We did it in Irvine about 10 years ago, and I think the audience was just could fill in just a small portion of this audience today. So AFTD has just done a wonderful job of getting the word out. It's a pleasure to be here, and I want to talk a little bit about some basic ideas and history of frontotemporal dementia, frontotemporal degeneration, and then I'll talk a little bit about non-pharmacologic management. In the course of this, I'll point out some things that are developing, an update on what's happening in the field. First of all, Let me put it in the context of dementia. Dementia is, of course, a decline from a prior level of functioning affecting cognition and behavior. Now, the frontotemporal dementias or degenerations comprise only about 8% of the pie. However, this masks the fact that it is a disorder that affects people in the prime of life at a younger age when it's unexpected and is therefore orders of magnitude more devastating. I don't need to tell you this. Historically, this began with the observations of a German-speaking neuropsychiatrist in Prague at the time of the Austro-Hungarian Empire. And he observed some patients, particularly one patient who had a progressive decline in language. But it was only many years later that Alois Alzheimer, German neuropathologist, found that these patients had these abnormal sacs of protein, which define the disorder, sacs of abnormal protein deposited in the nerve cells of the brain in the frontal and anterior temporal regions. These inclusion bodies are really central to this disorder, and part of the advances have been defining what these proteins are, because they are a rational target for developing interventions and therapies in the future. In the last 10 to 15 years, much of the development has been in defining not only the nature of the proteins, but what they do, and also when they are linked to an abnormal gene. Now, probably 13 to 15% or so of patients have a clear abnormal gene that we can identify, and that's a major clue to us because it allows us a vehicle to define mechanisms of disease and potential targets for intervention. So a little background on the FTD syndromes. Traditionally, they began with the three major syndromes illustrated here, two of them linked to language or primary progressive aphasias, and about 55% or so with a behavioral variant. Now, this is a little misleading today because we know that the spectrum of the frontotemporal degenerations is extremely broad. It ranges from amyotrophic lateral sclerosis on one end to progressive supranuclear palsy on the other. The message here is that we're talking about processes of neurodegeneration in the brain. And therapies and interventions that might affect ALS or PSP could potentially be applicable to behavioral variant FTD and to the progressive aphasias. So this is an area of research, and this is an area that I expect will yield important information in the future. So let's focus a little bit on behavioral variant FTD, which is the more commonly known variant. Not to minimize the others, but behavioral variant FTD is a disorder of what I call the social brain. I'll come back to that a little bit later here, but I want to point out the official clinical criteria, which involves 5 behaviors and then number 6, a neuropsychological pattern. Early behavioral disinhibition, which can be looked at as violating social norms and boundaries. Early apathy and inertia or a lack of productive behavior. Loss of empathy or sympathy or an inability to relate to others in an emotional way. Perseverative and stereotypical behaviors, and hyperoral and dietary behaviors, which are often carbohydrate craving, dietary fads, and in the extreme, with a few patients putting non-food items in their mouth. Neuropsychological profile tends to be sparing of visual, spatial, and memory, that are relatively spared. And this is how we diagnose FTD, behavioral variant. Today we have wonderful neuroimaging, major advances in neuroimaging. This is, of course, magnetic resonance imaging. And if you were to take your hand and put it over the top, and then alternately over the bottom of the top images, you would see, I think that you could see, that there is a lot of white or atrophy in the top that is not present in the bottom. The ventricles in that area enlarge, and this is a picture of frontotemporal dementia. We have developed a lot of radioisotopes that are aimed at the abnormal proteins in the sacs, those inclusion bodies. The radioisotopes of greater note are those that are tagging tau protein. Here we see frontal lobe dementia, which is, in this case, frontotemporal dementia, showing increased uptake of a radioisotope that tags for abnormal tau. So these are diagnostic advances that are going to continue to develop in the future, and we have several tau radioisotopes that are, one has been clearly introduced and several are being introduced. So this is a great advance for the future. Now, just briefly, the neuropathology and genetics, because that's been such a focus of development in recent years. There's variable neuropathology, and there's variable genetics. And you can read about this you could read the specific slides in the handout. The one word that I want you to remember here is the word variable. Both the neuropathology and the genetics are variable. This is not just one disease process. The neuropathology depends on what abnormal proteins are in those abnormal sacs, in those neurons. Sometimes it's tau, sometimes hyperphosphorylated tau, sometimes it's TDP-43, and there are a few other proteins around the world that could be implicated. So this is important because this is how we introduce drugs, anti-tau agents, and sometime in the future we're going to see an anti-TDP-43 agent, and so on, targeted at the proteins and their manifestations. The genetics is also variable, and just to let you know that there are multiple genes, again, throughout the world. They're listed here, and they are tend to be autosomal dominant. We'll hear more about genetics from my colleague, and so I will just emphasize the variability of this, and that it's not just one group of genes. This just simply illustrates the variability in the pathology and the fact that sometimes we find progressive supranuclear palsy, sometimes we find corticobasilar degeneration, and other types of pathology. This is a slide from my colleague Bruce Miller at UCSF, again just showing the variable manifestations of different genes. Okay, so I want to switch horses now and talk a little bit about management. I'm not going to talk about pharmacologic management. I'd like to emphasize non-pharmacologic intervention. That should be the first thing. How to manage this terribly impactful illness without using psychoactive medications, which we use, but let's first talk about behavioral management, changes in the environment, the importance of education, which you're doing here today, and care of the caregiver. Caregiver is the person or persons who do 99% of the heavy lifting. We know that as physicians, and you have to give a lot of thought to the well-being of the caregiver. So, what is the impact of on patients of all of these things? Loss of independence. There's a great impact on patients, so you have to think about that. And there's also an impact on the caregiver and on families. So I don't mean to dichotomize this, but it's good to remember to look at both things and not just the patient like you might in a number of other illnesses. For the patient, there's a loss of independence. Their role in the home changes, often from the dominant, maybe individual who is prominent in his or her job, perhaps in various aspects of the family unit, in taking care of children or other or financial issues. All of this loss is quite impactful, and there can be a lot of social isolation and certainly a loss of the sense of self, a loss of the sense of alteration of that subjective self in the mirror of the mind as you have a past, present, and future. The impact on families is also something that you have to look at. There's a change in the balance in the family dynamics and altered family roles. So it turns out that one person who's the person who is the main caregiver is now dependent on someone else, and all of these things can get quite complicated. There has to be a lot of family resilience, and one issue that keeps coming up is children, how to discuss this illness with children. Now I want to finish with some discussion of social behavior, because that's my area of research, and I believe that a lot of the region that it's affected is dedicated to social interpersonal interaction, that's the secret of humans, and that's how they evolved and developed, and as social units, that's how they defended themselves, and that's how they were able to succeed in early days of human development. And so a lot of that part of the brain has to do with what I call neurology at the +1 level. That is the synchrony between people, the interpersonal connectedness within people. And this affects, disease there affects that synchrony, resulting in detachment, apathy, inertia, as well as disinhibition, violating social norms and manners, altered interpersonal connectivity, loss of empathy, and altered communication. So to focus on these 4 things, first of all, studies have shown that apathy perhaps has the most impact on the marital relationship in patients. This, so providing some structure, offer or direct individuals to groups, small group activities, let them passively participate without forcing them in these activities, ensure that the tasks are simple, explain everything in simple language. There are things you can do for disinhibition as well. A number of years ago, we had the International FTD conference in Munich, and I spoke to the caregivers at that conference, and we talked about a study. We talked a great deal about this study where they found that behavioral disturbances were so prominent it was resulting in a lot of hospitalizations. There are things that you can do about that as well. Identifying triggers is important, and preventing exposure to those triggers, avoiding confrontations, reducing environmental stimulation, involving other family members and caregivers, and if a person is really disruptive, informing others about what does or does not work. That third area of social behavioral disturbance, altered interpersonal connectivity, is, in my mind, one of the most devastating things. Early in my experience with FTD patients, I had a patient who had whose wife was, he was the patient, his wife was admitted to the hospital with breast cancer. And it was touch and go with her. And he was left alone at home. And he didn't make any effort to communicate with her, except that one day he couldn't find the potato chips in the cabinet. And that's when he called her in the hospital. And that's how I saw them. She was obviously did not understand what this detachment was, and that there was no empathy. So you have to rethink the expectations on emotional feedback and on this type of reciprocity, and provide them information about others' perspectives around them, and encourage family to share what they've done together, and instruct others about validation of emotions. So this connectivity, you can deal a little bit better with this interconnectivity. Now, communication's a little bit easier to talk about. There are lots of approaches to communication. Approach with a calm, patient voice, reduce competing stimuli, use the same terms constantly, try other forms of communication, and even employ technology. So this is just a brief introduction to some of the things that we try and do. You'll hear a lot more of this in the sessions this afternoon. It will be clarified and amplified. So I just want to emphasize again, behavioral management, changes in environment, concern for the caregiver, beyond introducing pharmacologic agents. So this quote, worst strain, emotional distress, lowered perceived control among FTD caregivers, that's in comparison to Alzheimer's disease caregivers. So in many ways, being a caregiver for a patient with behavioral variant FTD is worse than being a caregiver for someone with Alzheimer's disease. So you have to practice caregiver wellness, find balance, have realistic expectations, reach out and talk to others, and employ support groups that are dedicated and know about this illness. So, in sum, we've come a long way since the time of PIC. We have still a long way to go, but there are drugs being developed. We've recognized the proteins. We know some of the mechanisms thanks to the genetic studies, and I think that the future for us is looking much better than it did just 5 years ago or so. I want to thank you very much for your attention, and I hope that I've helped you a bit understand this illness. Thank you.
Okay, thank you, Dr. Mendez. It's now my pleasure to introduce Jamie Fong. Jamie is a genetics counselor at the Memory and Aging Center at the University of California in San Francisco. Jamie is also a facilitator for a national phone support group for FTD and for the adult children who are affected by FTD. So please welcome Jamie Fong to the podium.
All right. Hi, everyone. Thank you, Dr. Natton, for the introduction. Thank you to the AFTD for the invitation to speak with you today. I'm honored to be here and to spend the day with you. Today, I will be speaking about advances in FTD as they pertain to the family. Surely this topic will come up again over the course of the day, and I hope that this talk serves as an introduction. So you've received a lot of information just now. You may be wondering, how do I put all these puzzle pieces together? How do I make sense of these discoveries and breakthroughs that are happening in the field? And more specifically, what does this mean for me and my family? And if you are sitting there and thinking about how a loved one's FTD diagnosis might affect your family, there are a number of things that you can do to begin to address this. And so, for starters, if you haven't already, I think it's helpful to gather information about your family and about their health history and to document this. It's at that point, once you've taken a look at the family history, it's prudent to begin the conversations about the possibility of genetic testing with relatives, if that hasn't already been done. And certainly, as you embark on this path, it's also prudent to reach out to a genetics professional to help you work through the history and maybe even help facilitate testing. And then finally, there's reasons to consider participation in research, certainly with the availability of genetic information in research. So these are the key points of my talk, and we'll come back to that. As we think about genetic testing as it pertains to FTD, it's helpful to step back and consider what proportion of FTD is actually genetic. And there's a spectrum. At the one end, we've got genetic FTD, which is about 10% of all cases of FTD, or 10 to 13%, as Dr. Mendez shared earlier. So 1 in 10 people with FTD will have a genetic form. And by genetic form, I mean there is one gene that harbors or has in it a change or mutation that leads directly to someone's symptoms. At the other end of the spectrum, we have sporadic FTD, which accounts for about 50% or half of all cases of FTD. And if there is a genetic, and it's sporadic simply because we don't know why it happens in people. And if there is a genetic contribution, that contribution is likely distributed over many genes, each of which with small impact, and we'll come back to that. And then somewhere in between is multifactorial FTD, or sometimes what I call familial Ftd, which comprises about 40% of FTD cases, or about 2 in 5 people. And the genetic contribution to multifactorial or familial FTD is somewhere in between that of genetic and sporadic FTD. So another way to look at it is if we take this jar, for example, and we draw a line, and we say that this line represents a threshold for FTD symptoms. And if we fill this jar and the contents don't reach or surpass that line, that threshold, FTD symptoms don't occur. But if we fill the jar and the contents surpass that threshold, we would expect to see symptoms of FTD. So, as I mentioned, genetic FTD is due to a single gene cause. There is that change or mutation in that gene, and that gene leads directly to someone's symptoms. Someone with the gene mutation will develop symptoms in their lifetime if they live long enough. And people without the gene mutation are not at increased risk for FTD. And so we can represent that here by this blue marble, where this represents the gene involved in genetic FTD. So as you can see, this marble is large enough that it alone surpasses that threshold. Symptoms will occur. And we see that there is no need for the addition of additional factors to make symptoms happen. So this is in contrast to multifactorial FTD or familial FTD, which arises from a number of factors. There are some genetic factors, there are some environmental factors, and together they put someone at increased risk to develop FTD. And if we took a look at that jar, it would look a little bit different, where we have the genes implicated represented by this pink marble, and the green marble represents environmental factors. So as you can see, the pink marble is not as big as the blue marble, and so one pink marble, two pink marbles alone is not enough to surpass the threshold. And in fact, it needs the addition of the green marbles to surpass that threshold. And so correspondingly, we would anticipate there to be genes with a moderate effect size that alone don't cause FTD, but rather with environmental factors together, FTD will happen. And this contrasts still further with sporadic FTD, where we might imagine that the jar looks a little bit like this, where there are a number of factors, both genetic and environmental, and the genes are represented by the orange and yellow marbles, and again, the green marbles represent environmental factors. And so here, again, genes alone aren't enough to surpass that threshold. Environment alone is not sufficient to surpass that threshold. And the key difference, I think, between sporadic and multifactorial FTD is the fact that perhaps the genetic contribution is a little bit greater in multifactorial FTD than it is in sporadic FTD, where each genetic factor has an equal impact as each environmental factor on the development of FTD symptoms. So again, as we think about the genetic contribution to FTD, it's helpful to think about it with two considerations in mind: the number of genes in one family, and then the degree of that gene's impact, or if it's multiple genes impact. So with genetic FTD, one gene, the impact is large. With multifactorial FTD, there are few to many genes involved, but each gene has a moderate impact. And lastly, sporadic FTD, where many genes are involved, each with small impact. So for decades, scientists and researchers have been attempting to characterize further these different categories of FTD: genetic, multifactorial, and sporadic. And so we've really benefited from the fruits of their labor, and we now know that there are 3 genes that are responsible for most genetic FTD, and again, most families with genetic FTD can be accounted for by mutations in these particular genes. And the first is MAPT, or known as the tau gene, also the progranulin, noted as GRN, and lastly, C9orf72, also known as the C9 or FTD ALS gene. And it's that particular gene that is the most common cause of genetic FTD and ALS. Genes involved in sporadic and multifactorial FTD have been elusive and are not entirely understood. Some risk genes have been identified, but surely there are others. So as we describe these different categories of FTD, you may be wondering, where does my family fit into these categories? So many families with sporadic FTD might look like this. So here we've got a pictogram of a family tree. We've got squares representing men, circles representing women. A diagonal line through a person represents someone is deceased. No diagonal line, they're living. A line between symbols represents a couple, and a line coming down from a symbol or from another line represents children. So here this person is shaded in red because he has FTD. And we see that there's no one else in his family with the same diagnosis or similar or related condition. And so we would expect that this person's FTD is sporadic. We don't know entirely why it happened, but it's probably not due to the 3 major genes that we know of in genetic FTD. And so if that person were actually to be tested, we would anticipate that his test result would come back negative, meaning no FTD-causing mutation was found. Families with multifactorial FTD are varied. Here is one example where we have a man with FTD, and his cousin has an atypical Parkinson's condition, and in fact, perhaps not written on this slide, that cousin was actually diagnosed with progressive supranuclear palsy, or PSP. So here, we would expect that that if one of those individuals were tested for the 3 major genes that we know of, that they too would test negative, meaning no mutation was found. And again, going back to that jar pictogram, it's likely that there are genes involved, genes that these 2 relatives share in common, but those traits that they share alone are not enough to cause symptoms, and perhaps other factors are involved, which is why one person developed PSP and the other one developed FTD. And then finally, families with genetic FTD are also varied. And here's one example where we've got one man with FTD whose mom died of ALS, and his uncle lives with ALS, and another uncle has an unspecified dementia, and that uncle has a son who has ALS. And the grandmother in the family, by report, died in a psychiatric hospital, at which time she was completely dependent on others for her care. And she carried with her a diagnosis of bipolar disorder in middle life. So this family history is very suggestive of a genetic form of FTD. And if this family were tested for one of the 3 genes, we would anticipate that a mutation in the C9 gene, which is responsible for the most cases of genetic ALS and FTD, would be the culprit here. So as we map out family trees in this way, there's value in thinking about who is at risk and who is not. There are healthy adult children who are often the focus of concern. And so for some of these families, their genetic risk can be quantified. And this might be information that they might want to know to plan for the future, to think about potential therapy trials that are becoming available. So now that we've looked at these family trees with kind of an analytical eye, where does that leave us? I'll bring you back to the 4 things that I pointed out earlier today. And if you haven't already, it's important to gather information about your family history. Talk to your relatives. Start with your parents, your siblings, your children, and branch out to adult aunts and uncles and grandparents. If you need to, reach out to the relative who is interested in genealogy. But keep in mind that dates of birth and death are not the only pieces of information that you're potentially interested in. So you want to ask questions like, who is living or deceased? For those who are living, what are their ages? How old were people who passed away in the family? Who has dementia? And was that dementia given a name? Was there an actual medical diagnosis? What was the age at first symptom? And what were the symptoms at the beginning of a person's illness, and how have they progressed? What are the symptoms now? And has there been genetic testing already done? And for those who have passed away, was brain autopsy done? You want to write all of that down. And once you have that family history information, you're going to want to discuss genetic testing in the family, or begin to identify who in the family is appropriate to be tested. So the adult healthy child may think, well, I'm at risk. I should be tested. I want to know to plan my future. So let's start there. I will say that unless the gene is already known in the family, the healthy adult child is not the best person to test first. And in fact, it's the people in the family with symptoms. So in this family, the man with FTD, his uncle or his cousin, they're the ones in whom testing should start first. You get the most information from that, from doing that first. So people with symptoms should test first. And you may be saying, well, what if my adult child isn't interested in testing, would do no differently with that information? Maybe I don't need to get tested myself. Testing is actually still helpful even when an adult child does not test. You never know if your adult child may change his or her mind in the future, and if you're not able to be tested in the future, or if your uncle and your cousin aren't tested in the future, well, then it can be a lost opportunity. So a healthy adult child can get tested first in a family, but there are limitations that I won't go into today. So hopefully I've been able to convince you that it's important to become a family history investigator, a genetic sleuth, if you will. And if you know kids' television programming, more like Carmen Sandiego and a little less like Inspector Gadget, or at least that's how my 6-year-old would describe it. So, as you embark on your sleuthing, it's worthwhile to reach out to a genetics professional. The National Society of Genetic Counselors has a website with a Find a Genetic Counselor feature to find someone in your geographical area. Alternatively, there is a large research network, which you'll hear more about today, known as Artful and Lefties, and individuals in that network can point you in the right direction. And then finally, consider participating in research. There is the opportunity to receive genetic information in research, and there are many centers across the U.S. that are participating. And there are some helpful websites as well. So on that note, I want to thank you again, and I look forward to the rest of the day.
I think that's